Access to Care Index. My name is Tasia Sin, and I'm a senior analyst here at the Colorado Health Institute, and I'm going to be moderating the discussion today. We have a couple of speakers who will introduce themselves in a minute, but before I turn it over to them, I want to go over a couple of basics about the webinar. The first is question asking. We hope that you all brought your questions today, and we would encourage you to ask them. There are enough people on the webinar today that we're going to keep everyone muted, so the way to ask your questions is to type them into the questions box in your webinar interface. And so I'll be moderating those and turning them over to the speakers and asking them as we go along. This webinar will also be recorded, and the PowerPoint slides will be available after the webinar. And so you can find both of those things on our website if you'd like to share this or listen to it again. And finally, I just want to thank our funders, the Colorado Health Foundation, the Colorado Trust, Caring for Colorado Foundation, and the Rose Community Foundation. So with that, I'm going to turn it over to Jeff Bontrager.
Thanks, Tasia. So yes, these are the three speakers that we'll hear from today. I'm going to give some opening remarks, and then I'll turn it over to Aubrey Hill, who's the Director of Health Systems Change at the Colorado Coalition for the Medically Underserved. And my name is Jeff Bontrager. I'm the Director of Research on Coverage and Access. And then we'll be hearing from my colleague, Anna Vigran, who's a Senior Analyst and Communications Specialist here at the Colorado Health Institute as well. We are really excited to have everybody joining us today for unveiling this very collaborative work with our partners at the Colorado Coalition for the Medically Underserved. I've been doing a lot of reflection lately because this past week I celebrated my 10-year anniversary at the Colorado Health Institute, which I can't believe that a decade has flown by so fast. But one of, I think, our proudest achievements here at the Health Institute is that we, along with our partners, were really able to shed light on the number of Coloradans who lacked health insurance, how many there were, where they're located, what their characteristics are, whether they're eligible for existing programs, coverage programs, but not enrolled. This is still vitally important, of course, but now that we have more people covered in Colorado, many of the conversations at the policy level, at local level, et cetera, are necessarily changing to access to care. So are people getting the care that they need? And it's a very complicated picture, but our goal is to bring the same amount of energy and enthusiasm that we brought to looking at uninsured rates to looking at metrics of access to care. And of course, the work is not done. Lots of people around the state are looking at other elements such as cost and health literacy and social determinants, and with the ultimate goal of improving health outcomes among Coloradans. So that's why I'm here, why I am so excited that you're here to engage with us. And this is a slide that is going to show, this slide shows kind of our agenda for today and what we're going to go over. Aubrey is going to start off by talking about how this work evolved from our initial conversations to really developing the index. And then she'll turn it back over to me, and I'll go over some of the key concepts for measuring access to care and the principles that guided our process. And then to conclude, Anna will provide a virtual tour of the index and what it's showing. So if I could, I'd like to cut to the chase and just give you three things that we'd like for you to go away with from today's presentation. First of all, as I mentioned just now, this index is an acknowledgement that we're moving from coverage to access and on to better health, and that's the underlying logic of this exercise. The second thing is that we created the index to examine the ingredients, if you will, of access to care, both over time and between different regions of the state and subpopulations. And we'll be talking more about that as we dive into the index today. And finally, what does the index actually say? Well, when you look at the overall scores, Colorado scores pretty well, about a 7.7 out of a score of 10. But that overall score masks some important disparities that we see when we drill down deeper into looking at the ability of lower income Coloradans or some within particular racial and ethnic groups in obtaining the access to care that they need. So with that, I'm going to turn this over to Aubrey Hill from the Colorado Coalition for the Medically Underserved, and she's going to kind of tell us the story of how these conversations started and what eventually led to the Colorado Access to Care Index.
Thanks, Jack. So for those of you who don't know, our organization, CCMU, defines the medically underserved as those who are at risk for poor health because of their circumstances or their inability to access healthcare services. CCMU works closely with many partners on ensuring that the state was able to attain and develop new coverage options for the year in 2014 through the Medicaid expansion and Connect for Health establishment. And we as a state have been planning these coverage expansions for many years, most prominently through the Blue Ribbon Commission in 2006. And in 2012 and 2013, we were expending much time at CCMU, and many of our partners were as well, working to implement these new coverage options. But as we all neared 2014, we were uncertain about what the coverage would mean for Colorado's ability to access healthcare services. Because they had a health insurance card didn't mean they would be able to get in to see a primary care provider. Didn't mean that we will see a reduction in emergency room use. We knew that gaining a health insurance card was not necessarily a guarantee that you would have access to health care for a variety of reasons. I referenced earlier the Blue Ribbon Commission as the roadmap for how we were going to transform Colorado's health insurance landscape for many. But as far as we knew, there was no similar roadmap for ensuring access to care for Coloradans. So we decided to reach out to some of our partners over coffee and ask some basic questions. Was there a roadmap that we at CCMU were not aware of? Was there conversations happening around the state to ensure that access was happening around the state that we weren't a part of, but we could plug into? Did anyone even understand what our access situation looked like? And after we had many cups of coffee with different folks, the answer was apparent that it was no. There was no master plan for how we were going to work on access. Now that coverage was coming, everybody started to agree that access has become even more critical to focus on. It was also clear to us that the complicating factor in all of this is that access needs to be driven out at the local level, not at the state level. Local communities have their own unique healthcare systems, resources, and cultures, and a blanket approach to access across the state would be short-sighted of us. So in early 2014, around this time last year, CCMU began convening a 3-meeting series of conversations around this topic. And we gathered all the statewide organizations in the room that we knew who represented providers, health advocates, health plans, hospital systems, local health foundations, and others. And we began sifting through some of the access to care conversation. And our conversation, as to be expected, touched on a lot of the different complicating factors of access to care. But we were able to arrive at a few conclusions. The roadmap to implementing the new coverage landscape was made feasible because there was a trusted set of data that informed our work. We could check in to see what our progress was over time and where we needed to hone in on to focus, such as different geographies or demographics that were lacking coverage. We needed something similar for access to tell us what the current state is and where we needed to focus our energy. We did some research and we discovered that California had done some of this work for Medicaid in compiling a set of metrics that covered the different aspects of access to care. And Anna will discuss some of the details, and Jack will discuss some of these details, but we thought we could expand upon California's idea and create a Colorado-specific access index that would go beyond just Medicaid. Additionally, we knew that communities experience access differently, and statewide averages, just like Jack said earlier, would mask those different experiences. So we wanted to ensure that such an index could be developed not only for statewide use, but local community use. And we're really thrilled that we're at this point after a long road of working on coverage and working on joining up what this possibly could look like and engaging different groups and folks to figure this out. So we think it would be a great and powerful tool for communities to use to uncover their current states of access and ground their conversations and action within the data. Now I'll turn it back over to Jack.
Well, thanks very much, Aubrey. As Aubrey explained, the question was how to measure access to care, somewhat like we measure coverage. We also wanted to start answering the question about policy changes that went into effect in 2014. How are policies designed to increase insurance coverage impacting access to care? We are measuring how many people have an insurance card, of course, and that has its own inherent complexities, but it's relatively straightforward. However, measuring everything it takes to have someone in an exam room with a care provider, like in this picture, is a lot more complicated. So does the patient know how to make an appointment or navigate the health system? Does the patient have transportation to get to the doctor's office or the provider's office? If you have insurance, does the clinic accept your insurance? And even if they do, can you afford the copay? So how do we measure access to care? Let's start with the goals of the project. So one of our goals was to give the big picture overview of access to care in Colorado, kind of the aerial view here. It provides a summary of what we've done with the index is to provide a summary access to care score. It's kind of a composite score. And it's a way to look at disparities between different communities. It also helps track change and disparities over time. Anna's going to go over this a bit more in depth later. But we didn't want to lose the on-the-ground sort of detail. We wanted to give people the information that they need to work at the community level. So one of our guiding principles with the development of the index is that we acknowledge up front that it's not going to answer every question that a community or a region has about access to care. Rather, it's a launching point for digging deeper and exploring the story behind the data. So again, how did we go about measuring access to care? As Aubrey mentioned, we were inspired by the work that Genevieve Kinney of the Urban Institute and Marcia Gold at Mathematica had done for the California Healthcare Foundation on access to care for California Medicaid enrollees. And they identified two aspects of access to care, potential access and realized access. So we'll start with potential access. This is really, I like to describe it as the building blocks of getting care. So do communities have enough care providers? Are their residents covered by insurance? Both of which makes it more likely that people will get the care when they need it. The second domain here is realized access, so care that people actually use. How many people are getting recommended preventive care, which indicates adequate access? How many people are getting the care that might have been avoided, such as emergency room admissions for a condition a regular doctor could have treated if one had been available, or hospitalized for conditions that can often be managed with adequate outpatient care, such as asthma or diabetes. We went a step further and we added one more category, which we're calling barriers to care. So this domain, this category really describes what makes it difficult for people to use that potential access. And which of these barriers can we actually measure? So we've included some examples here, such as the cost of an appointment. You couldn't get an appointment as soon as one was needed, lacking transportation, or not having a provider who accepts your insurance. The takeaway here is that we use this framework to figure out what metrics to use. So how did we go about selecting the metrics? Well, we first developed a list of criteria that we used to identify the metrics. And so we've listed them here. First and foremost, of course, they had to be related in some shape or form to access to care. We needed to have the ability to look at Colorado as a state, but also to drill down to important subpopulations of Coloradans, and then also to have it available at the geographic sub-state level. And then it was also very important that these metrics have the ability to be updated over time so that we could look at trends over time. So using those criteria to select the metrics, we undertook a comprehensive process of identifying metrics from a number of different data sources and then vetting them with different stakeholder groups. And in the end, it resulted in our metrics being drawn from 5 primary data sources. I'll just briefly go through each one of these. I know that a number of you are probably familiar with them. But the Colorado Health Access Survey really is the premier source of information on health insurance coverage, access to health care, how health care is used in Colorado. It's a survey that's fielded every other year, and the Colorado Health Institute fields and analyzes and manages that survey, and it's funded by the Colorado Trust. Our workforce data came from a database called Medical Quest, which is a database of practicing providers across Colorado, and it's compiled by the Peregrine Management Corporation. The next 2 data sources are surveys that are funded by the Centers for Disease Control and Prevention and administered by the Colorado Department of Public Health and Environment. The Pregnancy Risk Assessment Monitoring System, or PRAMS, is designed to monitor the experiences of Colorado women before, during, and after birth. And then the Behavioral Risk Factor Surveillance System, or BRFIS, is an annual survey of Coloradans ages 18 and older that's funded by the CDC and administered on an annual basis across Colorado. And it includes data on health risk behaviors and a number of other different domains within public health. Finally, the Colorado Hospital Association compiles admissions data received from all Colorado acute care hospitals. And we use this data set for looking at hospitalizations due to diabetes and asthma. So there's a lot more information on each of these data sources and which metrics we included from each one in a document that's called Data Sources and Methods that's available on the Colorado Health Institute's website. The final step that we did in developing the index was to develop a scoring methodology. And these access to care index scores provide a high-level measure of access to care. So overall, composite scores are available at the state level as well as for each region. And the way we've broken up the state is into 21 health statistics regions. These are commonly used geographic splits that are county-based. They're either single counties or combinations of counties, and there's 21 of them. We also provided a score for each of those 3 domains of access to care that I went over earlier. So we have a score for potential access, one for barriers to care, and one for realized access. The goal with these scores is a perfect 10. It's something to aspire to. So to score a perfect 10 essentially would mean that everyone would have insurance, there would be a sufficient workforce, there would be no barriers, and everyone gets recommended preventive care. So the index scores kind of give you this big picture. It's also a way to compare between communities to be able to identify disparities and see changes over time as policies take effect, such as more people becoming insured. Just a few tips here on how to use the index before I turn it over to Anna, who's going to provide a tour of the index. We've provided a detailed look at access to care at the community level. And what we would suggest is to start with the overview and then drill down. So start with the big picture, but don't just stop by looking at the overall index score. Dig a little bit deeper. So some indicators that we've included are available to look at over time, and this will be enhanced as we add additional time points in the future. And as I mentioned before, we hope that this will be used as a launching point for discussions on where to focus efforts and dig deeper at the community or regional level. And just as an aside, when we had discussions with various groups of stakeholders around Colorado when we were vetting this index, we heard that they would potentially use the tool for presentations to initiate conversations about other data that the community needs, the ability to compare the state to national trends or to help catalyze action both at the state legislature, attract medical training programs, data points for grant writing. It's very helpful to have those metrics all pulled together in one place. And then overall to inform decision-making around access to care. So with that, I'm going to turn it over to my colleague, Anna Vigran, who is going to dive a bit more into the details of the index.
Thank you, Jeff, and thank you, Aubrey, as well. So Aubrey explained the need for the Colorado Access to Care Index, and Jeff talked you through how we went about measuring access to care. So I'm going to introduce you to the tools that come with the Colorado Access to Care Index, where to find them, and how to use them. So first, there's an infographic, and there's one for the state and one for each of those 21 health statistics regions that Jeff talked about. So this infographic provides the overall index scores, the scores for each of those categories of access to care, and also shows some data that went into those scores. So we'll look at how this is put together and walk through it in just a minute. Also, for the data lovers among us, there is an Excel table for each of those communities with all the data collected for the index. So again, one for the state, for those health statistics regions, also by income and race and ethnicity. So all of those infographics and the data tables are available on the Colorado Health Institute website, and we'll have that address in just a minute. So that Excel table includes the 30 metrics that we looked at to put together this index. We use the most recent data available, which is to 2013, and we'll be updating the index later this year when 2015 data become available, and we're very much looking forward to being able to do that. So this first edition of the Colorado Access to Care Index really serves as a baseline measure for policy changes that went into effect in 2014. So the big Medicaid expansion, Connect for Health Colorado, lots of policy changes around insurance. This will be a way to measure the effects they had on access to care. So I'm going to go ahead and give you a tour of that infographic. Before I dive into those details, do we have any questions, Tasia? No. Okay, great. So I'll assume that we're being very clear, and if we're not, please go ahead and put questions in that box there on your screen. We'll take a few breaks as we go through looking at the infographic to answer any questions you have. Even though this is a webinar and we can't be with all of you in person, we do want it to be as interactive as possible. So send in those questions as they come up. So here is one of those infographics, and we're looking at Health Statistics Region 10. And I'm just going to talk you through what's on this layout. As our designer, Brian Clark, reminded us frequently, there's a lot of stuff on this layout. We kept asking him to fit more. So we just want to orient you to how that's organized and how we've been reading this. So at the top, it's Health Statistics Region 10, and that includes several counties: Montrose, Delta, Gunnison, San Miguel, Ouray, and Hinsdale. So they're on the western side of the state. And right up there at the top, next to which community we're talking about, is the overall score. So the overall score for Health Statistics Region 10 is a 7.0. And again, that's on a scale from 0 to 10, with 10 being the best, as Jeff described. So this overall score summarizes all the components of the index. It summarizes all of those data points, just bubbles them up to give that aerial view, if you will, that summary measure. So it's not a ranking. It's not comparing Colorado to other states. It's not ranking regions with other regions. It's just how well that community is doing in making progress towards that perfect 10, where everyone has insurance, there are no barriers to care, everyone gets recommended preventive care and can get other health care when they need it. So here, as Jeff described, there's also a score for each of those aspects of access to care. So potential access was building blocks, including insurance and a healthcare workforce. Barriers to care, things that prevent people from using that potential access, so cost of services, ability to get an appointment, things like that. And then lastly, realized access. What care are people actually getting? Are they getting recommended preventive services? Are they using services that might have been avoided with more supportive primary care, such as hospitalizations for uncontrolled diabetes or asthma? And finally here, I want to point out at the bottom, this is the website that will be showing up again in these slides as well, where all of these infographics are, where all of those Excel tables are, coloradohealthinstitute.org/CO Access Index. So When we had conversations with folks around the state as we were thinking through how to display this, how to pull this data together in the most useful way, there were a couple of themes that came up repeatedly, and that really informed how we displayed the data here. So I wanted to share those themes with you that were just top of mind for a lot of folks. So one topic that came up repeatedly was this balance of showing trends over time and the value of showing a particular point in time data. And we heard from communities that both were valuable. So you'll see here that there are some trends that are shown. So showing data from 2009, 2011, and 2013. And the trends that are shown are there are folks with health insurance and dental insurance. They're under potential access. People who reported not getting medical care due to cost or not getting dental care due to cost. They're under barriers to care. And under realized access, some kinds of preventive care. So seeing a dentist or dental hygienist in the past year, as well as well-child visits in the past year. So we wanted to show these trends because it's helpful to compare a region to itself, a community to itself, to understand how things are changing over time. And it's important to remember that things are always changing. So we expect things to look a little different from year to year. So when we're looking at trends to understand the effects of policy change, we not only want to ask, did things change, but how much, and in ways that we would expect or in ways that are surprising. So the trend data will be available for all measures going forward. Some of it's shown here, and on that Excel table, all trend data currently available is included on that table. So another question that came up all the time was compared to what? Right? What's the benchmark? What's considered good? What are we aiming for here? How do we gauge what these numbers mean? And it's certainly helpful to have a comparison group. So we did this a couple of ways. One, in calculating those index scores, we use those aspirational goals. So everybody having insurance and nobody reporting barriers to care. So the index score uses that perfect 10 as the goal. But when showing data for health statistics regions, we decided to provide the state value to give a point of reference. So we've circled many of those here. And we decided to do this for a few reasons. Of course, the state value isn't always necessarily a good goal, right? Particularly if the state isn't doing that well on that measure. But it does provide a consistent point of reference. So it gives an idea of what the ballpark should be, if you will, or what the ballpark is, maybe not what it should be. So we included that with all the health statistics regions just to give that context, to give that reference. We also heard from many communities that they wanted to compare their access to care data to other communities that are similar to them, so maybe a similar size or similar population characteristics. They wanted to look at peer communities. And while we completely agree this would be very helpful, we decided we didn't want to make the decisions about what those peer communities should be. You know, there's a lot of local knowledge that informs what helpful comparisons are in doing your work. So while we encourage looking at the data that way, we put all of those data tables online and all of these infographics online, so you can go find communities that are of interest to you and make comparisons that are most relevant and interesting to your work. And by the way, we're very much looking forward to hearing what those are and learning from you as you use this tool. So that is an overview of what's on this, and we're going to get into the so what and share some of our key takeaways at the state level. Before I do that, still no questions. All right, I think we're being very clear. That's exciting. And if they come up as we keep going, please go ahead and type those questions into the box on your screen. And Tasia will let us know when they come in. So moving on to looking at the statewide infographic. So I'm going to go over some key things that I take away from looking at this data. Of course, we're really into this and can talk about this all day. We won't do that to you. But we'd be happy to talk about it more if you guys would like to get in touch. So overall, I'm going to see if I can use my pointer here. Maybe I can, maybe I can't. Yeah, I don't see it. So overall, follow along with me here on the upper right. The state score is 7.7. So it's a 7.7 out of 10. That's pretty good. So that shows us that most Coloradans can get health care when they seek it. And then below that, we see scores for potential access, barriers to care, and realized access. So the potential access score is a 7.4, which is still pretty good. It reflects some lower insurance rates. What catches my eye in particular is dental insurance. So in 2013, just over 60% of Coloradans had dental insurance. Things like that are bringing that index score for potential access down. Another thing here that it catches my eye is looking at workforce. So we're looking at the ratio of certain kinds of medical providers, healthcare providers, for every 1,000 residents. And we all know that there are lots of models for providing care, and there's no magic number for any of this. But I think it's particularly interesting to look at these workforce numbers in the context of other data shown here. So for example, under barriers to care, there's a question about couldn't get a doctor's appointment when needed. So looking at that workforce in the context of other measures and other numbers here, I think is helpful. Moving on to those barriers to care, that score, that index score, is the highest at an 8.9. And a score of 10 is always good. So a perfect 10 would mean there are no barriers to care. So a score of 8.9 indicates that most Coloradans haven't gone without care, at least not for these reasons that we're measuring here. Now, a couple things to keep in mind. One is that not everybody seeks care or particular kinds of care in a given year. So, for example, not everyone will be seeking care from a specialist. Not everyone will seek mental health care in a year. So if people don't go looking for care, they don't report barriers in getting that. So as a population isn't seeking care less often, either because they're healthy or because they just don't think they need the care, that brings up this score. It's also important to look at the numbers behind these percentages, and those are available on the Excel spreadsheet. So in 2013, 19.3% of Coloradans couldn't afford dental care, and that's almost 1 million people, so that's a lot of folks. Even smaller percentages have large numbers at the state level. So for example, 7.8% of Coloradans didn't get needed mental health care in the past year, and that's more than 370,000 people. So we really encourage you to use those Excel sheets and these infographics together to look behind those percentages and see what kind of numbers you're talking about. A couple things to watch going forward. That barrier of not being able to get an appointment when needed. It'll be interesting to see if more people have insurance, if more people report trouble getting an appointment. So we'll be keeping an eye on that. And also all of those cost barriers, as more people become insured, will cost be less of a barrier, or might folks be underinsured and cost will remain a barrier for many people even with insurance. So moving on to the right to realized access, that index score is the lowest at 6.8. So that doesn't surprise me. Barriers to care that we have measured here certainly is part of the reason that that realized access score is lower than that potential access score, but there are probably other things going on as well. So there are barriers that we don't have measures for, such as language or cultural differences that make it hard for people to get care. Another thing that came to mind as we were looking at these data were the problem of low health literacy. So people may not know what preventive care is recommended, and here we're measuring how many folks got that. Even if they know what's recommended, they may not know how to access it. So that could be using their health insurance or navigating the healthcare system. Also, we know that changing patterns of care can take time. So for example, looking at that measure of using the emergency department for a need that could have been treated by a regular doctor if one is unavailable. This is there on the lower right corner under avoidable care. Even if folks have adequate insurance or have gotten adequate insurance, and even if there's another care provider, they might take some time to change their patterns of using care if they're used to going to the emergency department when they need something. Lastly, I'd like to point out some trends across these three buckets, these three elements of access to care. So back on the left under potential access, we see some fluctuation in the percentage of Coloradans with insurance. There was a bit of a dip from 2009 to 2011, and then it went up again a bit between 2011 and 2013. Looking in the middle under barriers to care, that line graph of not getting doctor care or medical care due to cost, we see that that went up a little bit in 2011 and then down a little bit again in 2013. So what we're seeing is an inverse relationship between percentage of Coloradans with insurance and percentage of Coloradans reporting cost as a barrier to care. As more people have insurance, fewer people report that cost barrier to care. And that's what we would expect. That's sort of the underlying premise of having more people insured. And I wanted to point it out because I think it's an important thing to watch going forward. So we have 3 years of data here showing that relationship. And if a lot more folks are insured in 2015 data, which is what we would expect, will that same relationship hold with cost, or would underinsurance or other barriers be a big issue for people reporting cost and severity, and also for people using recommended preventive care. So digging a little, so at the big level, the state level, access to care looks pretty good. Colorado's doing pretty well. But that masks some underlying disparities, as Jeff described earlier. So here we're looking at a map of those 21 health statistics regions. And earlier we were talking about health statistics region 10, which is there in the western part of the state. And on this map, the regions with the darkest color there are the ones that score the best. So the state score of 7.7 or higher. And we see that all of those regions with higher scores are along the Front Range, with the exception of Mesa County. The lighter colored regions are the lowest scores, and those are rural areas. So partly this reflects the distribution of Colorado's healthcare workforce. When you look at those potential access scores, you see the most variation there. That includes insurance and it includes workforce. And we know that Colorado's workforce is concentrated in urban areas, so it's part of what we're seeing in this map. We also looked at access to care scores by income, race, and ethnicity, and we see disparities there as well. So low-income Coloradans, so those with household incomes low enough to be eligible for Medicaid, score lower on access to care than Coloradans with household incomes above 400% of the federal poverty level. Again, these data are from before the big Medicaid expansion of 2014 had gone into effect. They're from 2013. So when 2015 data are available, it'll be interesting to see if that disparity has decreased. Also looking at access to care by race and ethnicity, we see that white Coloradans score highest on almost every measure of access to care, with Hispanic and Black Coloradans scoring lower. So next steps on this access to care index. As I said a few times, and we're very excited about updating it in the fall when there's new data available. And that'll let us compare those scores with the current scores that we're looking at now to understand the effects of the Affordable Care Act on access to care in Colorado. We're also looking forward to working with communities to understand changes in access to care and how this tool can be used to guide local work. So we'll be doing that in partnership with CCMU. And if any of you would like to invite us to be part of conversations in your community about access to care, or just want to have a more detailed discussion about your local data, please let us know. As Jeff and Aubrey both said, in many ways this is a launching point for new discussions. This index tool is really most helpful, we think, in partnership with local expertise, so bringing the quantitative data along with the qualitative data of what's happening on the ground in communities and what the experience of accessing care is like. So we're looking forward to having those conversations and bringing that information together. Here is the website where you can find everything we've looked at today. In addition, there's a brief with high-level findings which has some more detail about what we've discussed. All those infographics, the Excel data tables, and documents with details on methods and metrics, as Jeff mentioned earlier. One thing to note, that web address is case sensitive, which I found surprising. So coloradohealthinstitute.org/C-O, capital A and access, capital I in index, and everything is there for you. Again, back to the 3 takeaways. Policy conversations are turning from coverage to access, and the Colorado Access to Care Index provides a way to compare access between communities and over time to look at those disparities and if they're changing. And Colorado scores pretty well overall, but as we talked about, there are those disparities by region, income, race, and ethnicity. So thank you very much for joining us today, and it looks like we have some questions. Great, so we'll go ahead and talk about those. We'll go back to any relevant slides. I did want to show you here is contact information for Jeff, for Aubrey, and myself. So we're happy to take some questions now. It looks like we have some time. But anything we don't get to or anything that you think of later, please don't hesitate to get in touch with us about that. So that said, I'm going to turn it over to Jeff and Tasia.
Okay, so we've had a couple of questions come in here, and so I'm going to moderate this and read them out loud. For the workforce category.
Yeah, so that's a great question. These workforce indicators, we went down lots of different roads in looking at how to score or how to include the workforce indicators. And on one level, we did not include whether a region was designated as a health professional shortage area or not as a metric on our dashboard or on our index here, for the main reason that not all areas in Colorado have gone through that designation process. So if an area is not designated as a health professional shortage area, it doesn't necessarily mean that they were not designated or that they had gone through the process and were turned down because they didn't have a shortage, but because maybe they didn't initiate the process to begin with. But I think the question is actually more getting at whether we use the same sort of methodology for the health professional shortage area, like the ratios for population to providers for our workforce indicators. And we did an expansive search of different ratios that were out there, and this is really, for any of you who work in the workforce area, this is really kind of a tricky area. So it was one that we did consider, and Anna, did you have anything you wanted to add about that?
Sure. One of the things we found most challenging with using HPSAs, and we did not use those cutoff points, if you will, those goals, because it's really a floor, not a ceiling. It's what's adequate, not what to shoot for necessarily. So we were looking for how many providers would be a 10, right? Would be good, would be optimal, or at least would be sufficient, as opposed to at what point do you decide it's really a critical shortage. So we used different measures, which we'd be happy to share with you if you'd like, to get sort of our best guesstimate at what would be adequate in a good way, not just showing a shortage.
Yeah. And I think there were a couple other questions or comments about the data sources and the ratios that we used for those workforce indicators, and we'd be happy to have a conversation with you offline about those. It gets really into the weeds really quickly when we dive into those workforce metrics. So they're great questions, though, so thank you.
So the next question we have here is, are there plans in the future to capture data on the ability to access substance use disorder services?
So we found it very important to make sure that this index included not only physical health indicators, but also behavioral health and dental indicators of access to care as well. And you'll see those sprinkled throughout the index. So to the extent that substance abuse disorders may be captured under the umbrella of behavioral health, we do capture that. We don't have any specific indicators right now on substance use disorders at all. I'm not sure whether we would be able to develop an index around a specific set of services or not. That's not something we've really talked about as a group, but certainly something we could bring to the table in the future.
Okay, the next question, how has insurance defined? For example, is it have any insurance or insurance that actually covers likely healthcare needs like essential health benefits plans?
Well, so I would mention that we actually have two indicators that are on the index that somewhat get at your question. The first is just an indicator of insured versus uninsured. So that comes from the Colorado Health Access Survey, and that's a point-in-time measure of whether somebody indicated that they had some type of coverage. That could be coverage through an employer, coverage through Medicaid or Medicare, or that they purchased on their own. So when you're looking at those uninsured estimates, that's what that is capturing, is did they have coverage at the point of the survey. And I would also refer people back to the fact that this was collected in 2013 as well. So those were the latest data points that we had available to us for the index. The second indicator was the underinsured, looking at whether people spent more than 10% of their family income on out-of-pocket medical expenses. That's how underinsurance is defined on the Colorado Health Access Survey. And so we included both of those because we thought it was important to not only capture whether people had insurance, but whether they had adequate insurance or if they were underinsured. And let me just add to that question around the insurance. The second part of that question was, does it capture likely healthcare needs? So again, going back, like the essential health benefits that are captured on, or that are offered on the health insurance marketplace. Again, we do not know the extent of the benefit packages when we survey people about their health insurance. And because these data were collected in 2013, it's prior to the implementation of those essential health benefits packages availability on the health insurance marketplace. So we're really looking forward to 2015 when we get data from the Colorado Health Access Survey that will capture the Coloradans that are enrolled in those new plans and reflecting some of the policy changes around benefits packages.
Okay, the next question is, will the index be available for smaller geographies like zip code level analysis?
At this point, we are limited by the data that we have. It's a great question, and it's one that comes up very often. Unfortunately, a lot of the indicators and the data that we have right now are only available at the county level. And I know that a lot of Colorado counties, those boundaries are somewhat arbitrary and not the most meaningful way of looking at it. But it would be wonderful to be able to bring it down to the sub-county level or the zip code level, but we just don't have the data on a number of these indicators to be able to do that. So at this point, we are keeping it at the 21 health statistics region level.
So this is Aubrey. I'm just wanting to add to a couple of points here. One thing we decided when we decided to put this together was that there was no way that this would ever become complete because there's too much data out there, and lots of communities have their own data and their own way of assessing their access situation. So what we envisioned when we were putting this together is that folks can use this as a conversation starter and as a starting place where they can supplement their sense of the community and their sense of the data on top of this index. So don't despair if you don't see any of the data that you were hoping to see in this index. We feel your pain. We know that it is, there are some gaps there, but we know that there's a lot of knowledge that communities pull that they can really supplement on top of this.
Another question here, are there plans to investigate why people with insurance choose to not access care in a timely manner other than the listed barriers here? For example, trying to surmise how people's perceptions surrounding health care affect their utilization.
So I'll let Anna or Aubrey jump in here if they have a response as well. But I think that's a very good question. It gets at a couple of things that we tried to capture in our state survey with the Colorado Health Access Survey, which is really in that barriers to care bucket about why people, even though they may have coverage, why they're not accessing timely care or why they had foregone needed care. It might be that there still is a cost barrier, or perhaps that they didn't have transportation or couldn't get child care, or that a provider wasn't taking their health insurance. Those are all sorts of barriers that we will be looking into with the Colorado Health Access Survey. We've looked into it in the past. We've included some of the metrics here. We'll be looking at it again in 2015 when the new data, the summer of 2015, when the new data from that data set come out. But I think that your point kind of touches on a larger issue of health literacy and whether, especially with a newly insured population, whether people really understand how to navigate the healthcare system. And this is a theme that we have heard continuously throughout Colorado around the need for not only health coverage literacy, but overall health literacy to be able to get the care that they need. So I don't have a great answer right now to that question, but Aubrey or Anna, do you have anything else you would like to say?
So I'll just add that we hope over time this index will be able to tell us the progress of getting people access to healthcare services, but it will also show us if we're not making progress in that area, and that will tell us if there's anything we need to be changing in this culture of healthcare reform. So that will be a useful thing that we'll be able to take away from this as well.
This is Anna. I just wanted to add to Jeff and Aubrey's comments. Clearly, this can't answer all of the questions, and in some ways, we really do see it as a success that all these questions come up. Just having a structure to have this conversation with the data that's available, and that always identifies the data that isn't available, at least not at the state level, not meeting those criteria that we had of trendable over time, available for all areas of the state, available for subpopulations. That said, that we know that there is local data in many parts of the state that's only available for that particular area. As Aubrey mentioned, really tapping into that community knowledge to use that information, and also to start those conversations about where to dig deeper. As we had conversations about putting this together, we had questions about how many Spanish-speaking providers are in my community. And we just don't have a data source for that, but it's a great question. So community work to look into things like that. There are clearly limitations to some of these data sources. So for workforce, we don't know FTE. It's just our best estimate of providers. So again, if that's identified in the community as a place to gather more information, do more focused work, we think that's great. So in some ways, the more questions that come out of this for discussion, we see that as a good thing, and are always looking for better data to build on this in any way that we can.
Well, thank you everyone for attending. That looks like the end of our question session there. So if you have any other questions, feel free to reach out to the presenters here today. Their contact information is on here on the last slide. And again, this webinar was recorded and the slides will be up on our website, so you can access them later. Thanks again and have a wonderful day.